Without further ado, let me introduce you to the first speaker today, Dr. Steve Lipschultz. Dr. Steve Lipschultz is Goodyear Professor and Chair of the Department of Pediatrics at Jacobs School of Medicine and Biomedical Sciences. He's also the President of the UBMD Pediatrics and serves as the Pediatric Chief of Service at Caleda Health and the Medical Director of Pediatric Services Business Development at the O'Shea Children's Hospital. He is a pioneer in the field of pediatric cardio-oncology. He's credited with have helped establish the field, and he has been the principal investigator of several landmark NIH-funded studies on the causes, treatments, and prevention of cardiomyopathy in children who are survivors of childhood cancer. I welcome Dr. Steve Lipschultz for his presentation.
Thank you, appreciate it. Welcome everybody. So I'd like to share some of the work beginning with the end in mind, cardiotoxicity after childhood cancer, and along these lines. So the research that we'll present has been funded by those sources, and hope to have you understand the persistence and progressive nature of cardiotoxicity in childhood cancer survivors, and to understand the current preventive and treatment strategies for cardiotoxicity, and to identify their strengths and limitations of their implementation in this population of childhood cancer survivors. A number of years ago, we were pleased to have given input into changing the paradigm of successfully treating childhood cancer as being the successful treatment being determined by the balance between oncologic efficacy on one hand and toxicity late effects as measured by quality of life for a patient and family over a lifespan. And along those lines, sometimes it's important to never forget, this was a child that I had the privilege of caring for that developed cardiac failure early, but then also 30 years after treatment containing anthracycline for childhood acute lymphoblastic leukemia. This patient was diagnosed at 5 years of age with ALL and received chemotherapy that included doxorubicin to a cumulative dose of 465 milligram per meter squared. Therapy ended after 30 months when she was in complete remission. 4 months after the end of therapy, she was diagnosed with heart failure, treated with anticongestive therapy, at the time digoxin and furosemide. Through the years, although she had that initial improvement, that early hit was associated with, in her teenage years, being diagnosed with dilated cardiomyopathy, treated with anticongestive therapy. She had recurring bouts of heart failure over the next decade, especially in the setting of intercurrent illnesses and stress. And at 27, she had other late effects, endocrinopathies, obesity, requiring bariatric surgery, vitamin and iron deficiency anemias. Over time, even though she was moving forward with her life and married and her job, she became less responsive to anticongestive therapy during bouts of heart failure. At 36 years of age, she received a heart transplant in an adult heart transplant program appropriate for her age, which was a transfer of care. 6 months later, some of the years of issues came up, and she electively stopped taking all of her medications, including those to prevent rejection. She refused follow-up, and within 2 weeks of stopping her treatment, she had a sudden cardiac death. Brings up a lot of issues of why we need to think about lifespan care for these patients and some of the issues that come up. And so that's enabled us over the years to understand the course of pediatric ventricular dysfunction as it applies to childhood cancer and its associated therapeutic toxicities and late effects. It's enabled us to then identify certain risk factors, and it's enabled us to validate certain biomarkers as surrogate endpoints. And this has enabled the ability to go and develop preventive strategies. These are progressively less effective as these numbers going from cardiomyocyte injury to maladaptive changes to cardiomyopathy to heart failure to pump failures or sudden death increases. We've focused a lot, and you'll hear in this talk, on primary prevention possible at number one, especially in high-risk groups, and secondary prevention being possible at 2, 3, and 4 along this line. It's also enabled us to look at treatment strategies. We know that there's a greater impact if you're treating symptomatic patients at higher numbers, but you get longer effects if you're treating at these lower numbers. So for these surrogate endpoints, they're potentially more useful with lower numbers if we validate biomarkers as predictive of outcome to help for alterations of the course with interventions, and they're more useful at the higher numbers for decisions about transplantation and other destination type therapies. One of the things I want to focus on now is anthracycline-induced cardiotoxicity, MOA as mechanism of action. Some of you may be very familiar with this, but and for that I apologize. But the anthracycline-induced cardiotoxicity, it's cumulative, it's mostly irreversible, it's dependent on individual sensitivity, it's unpredictable, it's underestimated. If you look at this cartoon, what you see here is anthracyclines can enter and bond with iron, form free radicals, and lead to cardiomyocyte apoptosis and death. And one of the things that we looked at was, are there certain children newly diagnosed with cancer who may have higher levels of iron, and would that be associated with more cardiotoxicity, and would that be something that before somebody receives therapy might identify a high-risk population for cardioprotective strategy or alternative, less cardiotoxic therapies? One of the things that we found is that when we looked at the associations between the HFE gene, that's the gene that codes for hemochromatosis, disease more common in adults with excess iron. And we found there was an association between HFE mutations and myocardial injury during doxorubicin therapy for children newly diagnosed with ALL. We found that about 10% of the children newly diagnosed with ALL had mutations we were screening for the HFE gene. And we found for those that had, in particular, the C282Y mutation of the HFE gene with higher iron, that for the 10% of children with that, their likelihood of having an abnormal cardiac troponin T indicating dead and dying heart muscle was significantly associated with more than an 8-fold increased risk of dead and dying heart muscle, as illustrated here. And that's what we concluded there. We also found that if we looked at the left ventricular characteristics by HIV carrier status 2 years after randomization in the same study, those that had the early increased cardiac troponin in their serum 2 years later had statistically significant more abnormalities with dilated left ventricles, LV dysfunction, thinner posterior wall thickness, and reduced LV mass when compared to normal. Anthracyclines for the treatment of childhood cancer, as shown here in the red, in recent years is still being used for more than half of childhood cancer patients. These include lymphoma, leukemias, sarcoma patients, patients with neuroblastoma, renal tumors, and the like. And those that have been treated with more than 27 years of follow-up of these patients, survivors of childhood cancer, have a fivefold higher risk of death from cardiovascular disease than the general population. And cardiovascular disease is the leading non-cardiac cause of mortality in these children in several studies. And radiotherapy and secondary risk factors also contribute to developing cardiovascular disease in childhood cancer survivors. Anthracycline-induced cardiotoxicity is cumulative. Increased cardiac biopsy grades are associated with higher doxorubicin doses. We showed that increased serum cardiac troponin T during anthracycline therapy correlated with decreased LV wall thickness, Z-scores in long-term survivors. We also found that myocyte injury appears to commence even with the first dose of anthracycline. And as shown below, the risk of heart failure before the age of 40 increases with the cumulative dose of anthracycline. This includes a graph with two different types, doxorubicin and daunorubicin, and the relative risk of heart failure exceeds 10 or 15% with higher doses with a median duration of follow-up of 17 years. Heart failure is one thing, but cardiac mortality is another. In this large study of childhood cancer survivors in France and Britain, over 86,000 patient years of follow-up when compared to the general population. The childhood cancer survivors at 10, 20, 30 years after diagnosis was significantly different than in the general population in France and Britain of similar ages. And rather than coming together, they were diverging over time. And that's death for all cardiovascular diseases. And for cardiac diseases, the same thing was noted as well. So it's not just morbidity, but mortality. On the other end, does it affect oncologic outcomes and efficacy if there's early cardiotoxicity? And in fact, a large children's oncology group, AML study, recently published that early cardiotoxicity predicted poorer oncologic outcomes, looking at event-free survival. Those with no LV systolic dysfunction had better outcomes for event-free survival and overall survival when compared to those that did have systolic dysfunction. We looked at what does it mean to have a little bit of asymptomatic LV dysfunction in the absence of heart failure. And we found that left ventricular contractility, if you're not a cardiologist, this is what we call the health of heart muscle cells. We found that after an initial exposure, the health of the heart muscle cells became progressively worse over time. What we found that was long-term follow-up of these childhood cancer survivors is essential to see if an early doxorubicin hit resulted in late cardiotoxicity associated with progressive cardiovascular morbidity and mortality. In this study funded by the National Cancer Institute of the Dana-Farber Cancer Institute Childhood ALL Consortium of high-risk ALL patients at a mean age of 4.8 years when they were diagnosed at time 0 here, during this first phase up to the red dashed line, they received doxorubicin. At the completion of doxorubicin, their stress velocity index of their left ventricle, LV contractility, normal is here at the red line with a Z-score of 0. It was significantly depressed. And over the first 6 years, there was some improvement in recovery of contractility coming away from cardiotoxic therapy. But with subsequent growth, pubertal development, and time, those that had early impaired contractility were significantly more likely to have late contractility during the first 12, 13, 14 years of follow-up. In looking at a large number of epidemiologic studies, not a large number, but studies with a large number of childhood cancer survivors at 20 years and 30 years, this asymptomatic LV dysfunction seems to be associated in related populations to increased cardiac morbidity and mortality, and it's pretty consistent no matter where you look. What we published in looking at patients with childhood ALL and teenagers with osteosarcoma is we looked at cardiotoxicity 8 years after anthracycline treatment of these childhood cancers. And we found there were two pathways. One pathway led to depressed contractility, unhealthy heart muscle. We found in our multivariable analyses that girls were more likely at the same cumulative dose to have late depressed contractility 8 years later. And clearly those that received higher cumulative doses had that as well. This has been also seen in adults. It's not just unique to children. And when the heart muscle is unhealthy, what we found that was statistically significant related to having decreased heart function as measured by left ventricular fractional shortening. We found another mechanism, and I'll refer to this later as the second pathway, that in growing children, those that were at a younger age when they were diagnosed or those that had increased length of follow-up, those were statistically significantly related in our multivariable analyses to having decreased LV wall thickness for body surface area. That in turn resulted in increased left ventricular afterload, a marker of stress on the wall of the heart, and the left ventricular fractional shortening was reduced. So either by having perhaps inadequate sized hearts for the body surface area, or having some of the remaining cardiomyocytes have impaired contractility. These are two different pathways. They're not mutually exclusive that can result in left ventricular fractional shortening being decreased. The magnitude of the effect in that same study was illustrated here. If someone was being seen 8 years after childhood cancer and follow-up visit, and they received 450 milligram per meter squared of doxorubicin as a cumulative dose. And if they were a male, they had about a 10 to 20% chance of having late decreased contractility. But if they were female, that increased to more than 40% probability. So the effect of gender was not inconsequential. We then continued to follow that same cohort of patients for upwards of 40 years. And this really made this a very unique cohort where each patient's course over time was really charted. We thought it might help people think of the outcome here by calling it Grinch syndrome after the Grinch that had a heart that was too small for the body. But what we started to find was that about 10, 15 years, the left ventricular end diastolic dimension Z-score normalized for body surface area went from being dilated to being too small for the body surface area. We found the left ventricular wall thickness was too small for the body surface area. We found the left ventricular mass Z-score for body surface area was too small for body surface area. And then with increasing time, the wall thickness and dimension became more appropriate for one another. But again, the heart was still too small. But this was again the group that was at diagnosis 4 years of age. So even at 40 years of follow-up, you're still looking at people that potentially are looking at decades of active future productive life, and their average cumulative dose was in a range that we would consider high dose, but not excessively so, 352 milligram per meter squared. So one of the early studies that we did was to look at, well, could we give these early cancer survivors treated with anthracyclines and enalapril, an ACE inhibitor? What we found was it did not improve long-term outcomes for these childhood cancer survivors. The improvements in LV structure and function induced by enalapril were transient. We found that after 6 to 10 years, the improvement was lost, and those that presented with heart failure either died cardiac death or needed a transplant by 6 years. We found that the primary defect, which was LV wall thinning, continued to deteriorate, and thus the short-term improvement was mostly related to lowered diastolic blood pressure. So that really wasn't going to help us treat these patients long-term. Short-term, yes, but not long-term. We then had funding from the National Cancer Institute to do a multi-center randomized prospective study of continuous infusion of doxorubicin. We compared that to those getting it in the more conventional way of getting this over a bolus over less than an hour. And this was 102 children with ALL that got it 12 courses, each course over 48 hours as compared to bolus within 15 minutes of infusion. We found that after a period where the cardiologists who did the measurements were blinded for 18 years, perhaps a record in the field of pediatric cardiology, when we were unblinded, there was no significant difference in LV structure or function between the two groups over a median follow-up of 8 years. Again, both groups, the bolus group in green and the continuous infusion at diagnosis with ALL before getting anthracycline, were hyperdynamic in terms of fractional shortening. But at the end of 8 years, both were depressed, and there was no difference between the two groups. And there was no difference in 10-year event-free survival on the oncologic end. And it was an extra month in the hospital, increased cost, increased thrombosis risk, and increased mucositis risk. So then it prompted us to look at dextrazoxane, and this partially acts by binding iron ions. So we looked at dextrazoxane binding iron before anthracyclines enter cardiomyocytes, with the idea being that binding to iron prevents the formation of iron anthracycline complexes, thereby preventing free radical release and cardiac damage. If you look at the cartoon, this is an illustration where the dextrazoxane binds to the iron, the anthracycline comes in, it can't bind, and there's reduced cardiomyocyte apoptosis as a result. When we studied this in rodents, my dear colleague Gene Herman and his team and myself looked at this in spontaneous hypertensive rats. And as we gave 7 doses of doxorubicin, you start to see myofibrillar loss and myocardial vacuolization. Looks pretty much the same. But when these rats got 12 doses, which is what the children were dosed with, those that got dextrazoxane, their heart myocardial architecture was preserved. Those that got doxorubicin alone, it looks very, very bad. That resulted in us doing an NCI-supported prospective multi-center NCI study of dextrazoxane before versus no dextrazoxane for children diagnosed with ALL, high-risk ALL, getting doxorubicin. This was unblinded a little bit prematurely because the cardiac troponin T, a secondary endpoint, was 50% of these children had dead and dying heart muscle in the group that got doxorubicin alone, only 20% or so in those that got treated with dextrazoxane before every dose. And as you look, the doxorubicin alone group had a typical dose response curve where the higher cumulative doses of doxorubicin were associated with more dead and dying heart muscle. And in the group that got the dextrazoxane, that did not occur. And when we looked at these same patients at the primary endpoint 5 years later, we focused here on this graph and looking at pathologic ventricular remodeling. I just borrowed this cartoon from an adult infarct slide, where here there's an area of infarct, over time if they're going to remodel. There's thinning of the walls, there's dilation. It's an adverse predictor of outcome. Our marker of pathologic left ventricular remodeling is shown here in the same group that I just showed you. Those that got the dextroazoxane even 5 years later did not have pathologic ventricular remodeling. Those that did not get dextroazoxane and just got doxorubicin had progressive remodeling of their LV in a pathologic way. The asterisks indicate the pairwise comparison was significant at each of those points. And then a second study that Barbara Aslin was the lead for the COG, and I was pleased to be part of the NCI Children's Oncology Group 9404 T-cell study. This was, I think, over 600 children, and dextroazoxane was cardioprotective 3 years after doxorubicin. Here, the pairwise comparison 3 years out. For fractional shortening, it was depressed. In those that got doxorubicin alone, it was normal. In those that got dextroazoxane, in terms of LV wall thickness, Z-scores for body surface area, the walls were much thinner than normal. In the group that got doxorubicin alone, it was normal. In the group that got dextroazoxane before every dose of doxorubicin, the pairwise comparison was significant. Looking at pathologic remodeling, those that did not get dextroazoxane had remodeling. Those that got dextroazoxane did not have remodeling, and that was statistically significant. So that was our second dextroazoxane study in children. Our third study of dextroazoxane in children was led by David Ebb and some of my other colleagues like Lisa Kopp and others, and I was privileged to be part in helping to lead the cardiac aspects of this. And here the question was additive cardiotoxicity for some of these patients with osteosarcoma during childhood and adolescent age groups that were pretty refractory to cure. If they were HER2 receptor positive, could they get Herceptin, trastuzumab, which is a cardiotoxic therapy in many people's eyes in terms of blocking repair in conjunction at the same time as getting doxorubicin. And we found by giving dextroazoxane, when we looked here at left ventricular fractional shortening, normal is in red. Both groups, those that did not get the trastuzumab in blue, those that did get the Herceptin in red, were not significantly different from normal. And that when we looked at the same patients in terms of NT-proBNP, a marker of ventricular cardiac stress, there was no cardiomyopathy. These were all, as a group, under the threshold of 100 in both groups. So it was protective in that giving additive cardiotoxicity. A fourth dextroazoxane study showed that it was cardioprotective with doxorubicin dose escalation. My colleague Cindy Schwartz led the COG studies, and I was privileged to be part of this. We're taking osteosarcoma patients and increasing them from 450 to an unimaginable 600 milligram per meter squared of doxorubicin. With that, there was no fall in left ventricular fractional shortened slope of doxorubicin when dextroazoxane was given. And again, both groups, those that got 600 in blue, those that got 450 in red, weren't significantly different from normal. A fifth dextroazoxane clinical study that we did that was just published this past year was the NCI COG osteosarcoma high-dose anthracycline studies, where we found that dextroazoxane prevented heart failure and systolic LV dysfunction, and it reduced. But the key thing is it did not prevent that second pathway. Remember in a prior slide I showed on the right, there was a reduced growth of the heart for the size of the body, leading to really restrictive physiology and a restrictive cardiomyopathy. And what we found here and what we recently published was that there was smaller left ventricular dimensions, Z-scores for body surface area in females compared to males and compared to normal, and with increasing cumulative doses, even in the setting of getting dextrazoxane, those LV structural changes were not prevented. They were less, but they were not prevented. And as a result of having a smaller LV dimension for body surface area in this study, when we looked at the NT-proBNP here, the hearts became abnormally small for body size with higher LV stress. So you see the females, the NT-proBNP with increasing amount of anthracycline, even with dextrazoxane. It didn't completely prevent cardiotoxicity from developing in females. We did a 6th study of dextrazoxane in kids. This is a currently funded NCI R01. My colleague Eric Chow in Seattle is the main principal investigator. I'm a principal investigator as well, and we've been looking at this in all of these COG studies and Dana-Farber studies where people were treated with dextrazoxane, and 18 years after treatment, we were interested in seeing, did dextrazoxane reduce future clinically significant cardiometabolic risk in these anthracycline-treated childhood cancer survivors? In the interest of time, I can't really get into that degree of the work that we and others have done. But here we found that these patients that were treated with dextrazoxane still had moderate risk for subsequent ischemic heart disease becoming symptomatic, and were also at moderate risk for heart failure following CCSS risk calculator. And compared with NHANES, the survivors had fewer metabolic syndrome features and were more physically active and smoked less tobacco, but they had more hypertension and similar rates of obesity, diabetes. But at the bottom line here was that the dextrazoxane didn't prevent this increased risk. It wasn't different in those that were treated. The other thing that comes up with dextrazoxane, this is a study from the whole country of South Korea, where about 1,500 patients were looked at that either got dextrazoxane or not, recently published, showing there was no difference in overall survival after dextrazoxane treatment. One of the concerns had historically been that this could reduce oncologic efficacy, leading to more mortality. It wasn't found. So why is this still a problem in long-term survivors after being treated and not having seen an anthracycline for years? What we found was there's accelerated mitochondrial aging with doxorubicin, and this is attenuated by dextrazoxane. In one of the large NCI studies we did, we looked at mitochondrial DNA, and we looked at the distribution of confirmed mutations or polymorphisms. And we found that in the cancer survivors, childhood cancer survivors, 30% had one or more change. Some of these were potentially pathologic mutations, well known in other settings. And compared to healthy controls that only had 12.5%, there was a statistically significant increase in mitochondrial DNA mutations. And then in a 7th study of dextrazoxane in kids, we found that when we looked at the mitochondrial function, so it's not just are there mutations or polymorphism, but what's the function? We found that oxidative phosphorylation complex 1, complex 4 activity were unchanged between these children that got doxorubicin alone or those that were randomized to dextrazoxane. But when we looked at the number of copies of mitochondrial DNA per cell, it was more than 3 times higher in those that did not get dextrazoxane. Those that got dextrazoxane before every dose of doxorubicin, the mitochondrial copy number was similar to what we see in healthy children. So there is a significantly higher number of mitochondrial DNA copies in doxorubicin group suggesting that the way these survivors 10 years after treatment for ALL, who are just teenagers, are maintaining oxidative phosphorylation and generating energy for myocytes, perhaps are doing this because there's a compensatory mechanism to have more copies per cell in these damaged mitochondria, which doesn't have a great long-term likelihood of being successful. We noted this past year that our colleagues at the Children's Oncology Group, AML, had a study with over 1,000 patients, and they compared dextrazoxane in that setting, and they found that it preserved cardiac function without compromising event-free survival and overall survival, or increasing non-cardiac toxicities. And in the COG study, they recommended that dextrazoxane should be considered for cardioprotection during frontline treatment of pediatric AML. They found that the dextrazoxane treated patients on this protocol, as they looked at it, had significantly preserved left ventricular ejection fraction. And again, the dextrazoxane had no negative impact on event-free survival, overall survival, or non-cardiac toxicities. And in fact, there was a feeling that dextrazoxane may actually increase event-free survival and lower treatment-related mortality. In an 8th study that we've done related to dextrazoxane, again, my friend and colleague Eric Chow and I have had the privilege of being PIs on this study called the HEART study. And this is a study of the health effects of anthracycline and radiation, looking at dextrazoxane and heart function among long-term childhood cancer survivors. This is currently an active study at 72 sites, mostly around the United States. Yes, we do have Perth, Australia, and some others, it's bringing back these children that were treated years ago, 18 years ago to be exact, with dextrazoxane, that were randomized and looking to see is there a sustained improvement in cardiac status 18 years later. They received an average of 302 milligram per meter squared. And this is from that same study. What we are finding is that dextrazoxane is associated with better heart function and less heart stress. If you look at here at left ventricular function, shortening fraction, ejection fraction, they're both significantly better in the group that were treated with dextrazoxane 18 years earlier than those that were not. And same thing's true for myocardial stress. Both BNP and NT-proBNP are significantly lower in those that received dextrazoxane compared to those who were not. We found that the dextrazoxane cardioprotection is more pronounced in females and those who received higher anthracycline cumulative doses. This is the sex interaction, and you see where that comes in. And this is the dose, and you can see where that comes in. And so this is an active study, but again, lower left ventricular function is less common with dextrazoxane. And our 9th study in dextrazoxane in patients is when we published this past year, and it's the use of dextrazoxane in a different population. So somebody that's presenting with cancer that has pre-existing cardiomyopathy. So now they have pre-existing cardiomyopathy and cancer, and the thought is to give anthracycline therapy. We found that in a consecutive series, single center, we found that in the initial group that didn't get dextrazoxane all developed heart failure, which was fatal in 2. We found that in the next group that all received dextrazoxane before anthracycline, although the EF fell, none developed heart failure, had a cardiac death. So for this limited series, it's a hard population to study. Dextrazoxane prevented cardiac decompensation in patients with pre-existing cardiomyopathy receiving anthracycline therapy. And doxorubicin cardiotoxicity is multifaceted, requires targeted multi-agent cardioprotection, similar to what we use to treat it. I just showed you that the administration of dextrazoxane attenuates iron complex formation and ultimately may protect mitochondria, as we were just going over, and the like. But again, in some of our studies and those of others, immunomodulatory therapies giving more precursor for mitochondrial precursor depletion, improving calcium balance, and others may be part of multi-agent cardioprotective strategies. Another area that I just wanted to briefly touch on, because the mechanism is really different and the outcomes are significant, is childhood cancer survivors that were treated with radiation that included the cardiovascular system, particularly the area around the heart. So this was a study we did where patients received 30 gray irradiation to people that had a median age of 15 years of age for Hodgkin disease. And even though it's modern era therapy with screening in appropriate ways, there still are areas that were potentially exposed. And what we found was 16 years later, so these people were in their 30s, they were set up for potential future morbidity and mortality. What we found is they had the well-preserved systolic function, but fairly prevalent diastolic dysfunction with a restrictive cardiomyopathic pattern at risk for heart failure. Valvular heart disease was surprisingly common, and risk for endocarditis, intracardiac conduction defects, at risk for sudden death, coronary artery disease, at risk for heart attacks, and others. And what we found was that these were progressive findings, and they may become apparent clinically 10 or more years after radiotherapy. And the findings may be unsuspected but clinically significant, and that serial comprehensive cardiac testing is advised. And unlike the loss of heart muscle cells related to anthracycline use, radiotherapy is related to, in some cases, progressive fibrosis years after therapy. In this particular study of these 16-year survivors after mediastinal radiation for adolescent Hodgkin lymphoma, there was decreased quality of life and physical functioning. All of the patients in our study rated their overall health as good or better. However, on our more general health survey, 2/3 had fatigue. For half, it was at least moderate. 40% had shortness of breath, 10% dizziness, 25% chest pain. And when we looked at an SF-36 quality of life validated instrument, here I've overlaid it on a study we didn't do that was published by others of adult heart failure patients, where this is a normal population. This is a New York Heart 1, a New York Heart 2, and New York Heart 3. When we looked at the physical functioning domain, our 16-year survivors that all said they were doing well, but had those symptoms, at least on an SF-36, they were falling into the New York Heart 2 to New York 3 range. We subsequently published, we brought these people back, and 5 years later, we looked at them again, and they were actually continuing to fall, even, so they're in their mid-30s, many years away, but it's affecting their quality of life, physical functioning. So when you look at this, I brought up how do we prevent anthracycline toxicity. We've been really interested in protecting against radiation cardiotoxicity. There's a number of things. Yeah, you can always reduce radiation, but it's not practical in many settings. And there's been a lot of work to target precise radiation doses to reduce scatter, and that's hopefully going to be, with longer follow-up, helpful. Some of the other things have high side effect profiles. Others have been explored. My colleagues in Buffalo, Dr. Sharma and Dr. Pokarl, have had recent success at a couple of new NCI R01s, and pleased to be part of their work there. And looking at what, at least preclinically, is a very effective cardiac radioprotectant that works at reducing the constant low-level inflammatory effects by doing this. So again, this is we're just one of a number of places that are looking at strategies to reduce radiation toxicity. So just to conclude, Cardiotoxicity associated with cancer therapeutics can be pervasive and persistent. They can be progressive but missed clinically. And cardiovascular related health burden increases. It's an expanding population. Genetic, I showed some genetic predisposition, other factors that can interact to cause toxicity and identify high-risk groups for safer treatment options and targeted interventions. And continuous infusion, at least in the study we did with high-risk ALL, didn't have any long-term cardioprotection compared with bolus. Enalapril, in our hands, delayed but didn't prevent progressive survivor toxicity. Dextrazoxane in the 9 studies I showed you that we were involved with was protective, allowed safe dose escalation, the use of additive cardiotoxic therapies, and the use of anthracyclines for patients with pre-existing cardiomyopathy. And it's an opportunity to encourage more pediatric oncology protocols for children treated with doxorubicin to use dextrazoxane before doxorubicin dosing, and to do so in the setting of clinical trials so we can learn about these. And that tailored follow-up and therapies, these multi-agent cocktails, should be developed more as we understand more of the different cardiotoxicities. I showed that the persistent mitochondrial damage may relate to lifespan cardiotoxicity. Showed an example of one gene mutation where screening for hemochromatosis gene mutations in children with newly diagnosed high-risk ALL might inform treatment decisions, and continuing to follow in the relevant parameters where they might actually have late effects becomes important. And I tried to show a little bit that the late cardiovascular toxicity following mediastinal radiation is common and significant for survivors of childhood cancer. Thanks.
Thank you so much, Dr. Lipschultz. That was a phenomenal talk with so much data. We know that the studies that you've done and the knowledge that you've given to the world has greatly informed all of us how to take care of patients who've been affected with anthracycline-induced cardiotoxicity, as well as radiation toxicity. And like you rightly pointed out, there is a growing body of evidence, but we all need to come together and collaborate to increase this evidence and create more evidence. So we have a few questions. So the first one is by Miguel Urzapana. They're asking, how would you evaluate reversible and non-reversible cardiomyopathy in a patient who's undergoing cancer treatment, apart from drugs such as anthracycline and doxorubicin? What are the mechanisms and what are the methods that you would use?
Yeah, thanks. It's a great question. And I think that this is where it's important to have a field like cardio-oncology where we can coordinate. No one center necessarily sees enough of these patients in real time. We've benefited by having the courage to honestly define that we don't know the answers to that. And if we work together, pool our data, we can understand better what's truly transient, what's not transient, what are the interactions, which groups might have highest risk. I think right now, you bring up really important points because, in pediatric, we're just starting to see therapies that are known to have vascular and cardiac toxicities in adults come in, whether they have the same toxicity profile in terms of reversibility or irreversibility, unclear. And so in terms of monitoring, like I said, you have to be careful because, if you don't look, you don't know. But the more you look in an asymptomatic patient, inevitably you're going to find subclinical cardiac abnormalities. And you got to be really careful because at the end of the day, as a cardio-oncologist or an oncocardiologist or somebody that's just interested in this field, it's really hard not to act on data in an asymptomatic patient, yet we really don't know in an asymptomatic patient whether acting on numbers that are abnormal where we don't know is it likely to be reversible or not. And we're up against really trying to cure a fatal disease and not create another is really an important consideration. So thank you for bringing that question up.
Great, thank you so much for answering that question. Another question that was posed by Bishay Zerdoki was that wonderful lecture, Dr. Lipschultz. Could you please comment on the possible mechanisms of the sex difference in doxorubicin cardiotoxicity? And why do you think dexrazoxane is more cardioprotective in girls?
Well, we don't know the answer to that, but it was a pretty consistent finding in most of our studies, and it goes actually even beyond just anthracycline toxicity. We find that there's a similar distribution of toxicity in young children getting therapies that can affect similar pathways, such as antiretrovirals in those with HIV in children. We find that even for cardiac surgery on pump runs in young children, there's a similar age distribution. And we find here that there's more toxicity in girls than boys with anthracycline. We also find there's more cardioprotection in girls than boys. If you postulate that a lot of the mechanisms of injury relate to free radical and free radical protection, you could speculate that whether you're on cardiopulmonary bypass, whether you're getting other therapies that could affect the heart if you're getting anthracycline, maybe there's a less protective mechanisms in young girls compared to boys in terms of this. It's highly speculative. We've had to publish other speculative reasons, such as dosing by body surface area. Since anthracycline doesn't absorb as well in fat, it might mean that heart might get more toxicity than girls at higher doses, and the clearance is different by kidney and liver and in girls and boys, and that might contribute. But it's a really good question, and I don't know the answer.
All right, thank you so much, Dr. Lipschultz. One last question, and then we'll move on to the next talk. Is Veronica from Brazil is asking, what is your opinion about the use of carvedilol when dexrazoxane is not available?
I think the data is limited for the use of beta blockers. Some of the papers and series are more anecdotal. And the point is that when we've looked at the drugs we use to treat cardiac dysfunction and heart failure in children, they're not necessarily etiology-specific therapeutics. And that's where understanding the mechanisms and then targeting the therapies, I think, have the greatest potential. And I think, what we found in one of the studies I showed there is if you're reducing blood pressure, you'll get improved numbers, but are you really reducing the primary insult to the heart? I think it's less than clear, even in adult studies with long-term follow-up, how much long-term protection there is when, again, the mechanism is not necessarily directly being addressed. So, important question.
Yes, absolutely. And given the compelling data that you showed regarding the genetic predisposition, is there any role for genetic testing for anthracycline toxicity risk at this time clinically?
I really think that, the FDA has approved in other areas, not for cardiotoxicity, but for other chemotherapy-associated toxicities, doing either point of care or before initiating certain toxic therapies, genetic screens where there's a clear predisposition. It's almost unheard of to have a 9-fold increased risk of dead and dying heart muscle. And so here, I would like to think if we want to really reduce toxicity, HFE is only one of several gene mutations, but the effect on toxicity was striking, and it is an opportunity as our technology becomes more rapid and more advanced to identify those high-risk patients and use more protection or alternative therapies. I think it should absolutely play a stronger role, both in terms of identifying which groups of patients may be predisposed to having cardiotoxicity from a therapy, but also in identifying those patients that may have an underlying predisposition or having clinically occult genotype positive, perhaps phenotype negative cardiomyopathy. Because again, as I pointed out, in a group that had cardiomyopathy pre-existing, knowing that treating led to improved outcomes.